Greetings. In this video, let's talk about systemic lupus erythematosus, or SLE, or lupus. Okay. Again, we were in the arthritis portion. So just a reminder, patient comes in with a joint issue, a rheumatological issue, and the patient does have symptoms of inflammation, which would be swelling, redness, heat. Uh, so they have arthritis. If it's chronic in nature and has multiple joints that are associated with it, one of the things to think about is lupus. Okay, so that's where we are. Okay, so lupus. So let's continue working on it. Uh, Pathophys. What causes it? Um, Before we do that, how does it present? So again, polyarticular, as we covered, it is inflammatory in nature, symmetrical. So that's where it's different from a disease like osteoarthritis. Uh, it's got a chronic phase, and then you got flares, okay, of this disease, and then it's autoimmune. So again, it's where the immune system attacks itself. It's more common in females, and um, so that's one. Now, how does it come to pass? So there's generally a trigger: infection, drugs, ultraviolet rays from the sun or otherwise, and they cause cells to die. Once cells die and they unpackage, so again, there's necrosis versus apoptosis. So apoptosis is generally the cells disassembling. So once the cells disassemble, the nuclear material, or the DNA, which was inside the nucleus, now comes out of the nucleus. Okay? And these patients, lupus patients in general, have low complement system. So again, if you're not sure about the complement and how it works, take a look at my anatomy and physiology immune video on complements. Okay, but essentially that means this nuclear material hangs out in the body for a long time. Additionally, on some patients, on some people, there's some markers on the nuclear material which is susceptible to be tagged by antibodies. So these are genes that are susceptible genes to an immune reaction. So again, cells die in patients with susceptible genes, and they have low complement system, so it doesn't get cleared quickly. So now that these genes are out and the susceptible areas are out in the open, they get tagged by anti-nuclear antibodies, or ANA antibodies. Okay, so now you have antigen and you have antibody complex. So antigen, antibody complex. Okay, and this actually gets deposited in different parts of the body. Okay, and our immune system looks at it, doesn't like it, wants to clear it, and in pursuit of this damages that whole area, including the good tissue that's there. And that is the pathogenesis of type 3 hypersensitivity reaction. So if you're not sure about what type 3 hypersensitivity is, review my hypersensitivity video within the immune system. Okay, so again, that's type 3 hypersensitivity that causes immune response to be mounted and damage to the normal tissue where the antigen antibody complex is deposited. Okay, so that's sort of how lupus comes to pass. In patients, if you can think of Loretta from Family Guy, that'll give you a prototype patient, especially on your tests. So again, a female, and generally a minority. So African American, Hispanic, and Asians have higher risk. When it comes to symptoms, if you can remember MD, soap, brain, you can actually remember lupus. MD would be the skin manifestation, so that would be the malar rash or the butterfly rash. D is discoid rash, which is a plaquey, patchy redness on chronic sun-exposed areas. Malar rash, again, butterfly rash, is on the face generally, which gets exposed to the sun, but the nasolabial folds get spared because the sun light, the folds don't get the sunlight, so they get spared. Okay. Again, malar rash is one of the ones you see a lot in questions. I would look at a picture just to know what it looks like. You have serositis with pleuritis and pericarditis. One may have oral ulcers or ulcers in the mucous membrane of the nose. Arthritis, that's one of the areas that is within lupus. That's a symptom associated with it. You have photosensitivity, so that's S, O, oral ulcers, A, arthritis, P, photosensitivity. So they burn easily, sunburn easily. So that's MD soap. With brain, they've got blood abnormalities like low hemoglobin, low platelets. R would be renal symptoms, which would be lupus nephritis is the biggest one. A and I actually are blood tests. So A would be ANA. It is not very specific as a blood test, and just because somebody has a positive ANA does not mean they have lupus, because it's not very specific for lupus. Anti-Smith, which is the other immune test, remember A and then I, that's more specific for lupus. Okay. A lot of patients are negative for that one. So again, not very sensitive, but very specific for lupus. And then there's two other tests to remember. Antihistone, which when positive shows drug-related lupus, and then anti-double-stranded DNA or dsDNA, anti-dsDNA antibody, which is associated with lupus nephritis. Okay, so that's ANA, and immune tests, and that's the only four that I would know for lupus. Okay, and then N would be neurosymptoms such as seizures, and they count towards the diagnosis of lupus. Okay. Now, we figured out how to recognize the patient, what symptoms they come in with, and how lupus comes to pass. Now, there's a few odds and ends with lupus, so let's talk about that. So, diagnosis. The patient comes in, okay, of course, their symptoms are screened, and you see a lot of soap brain, MD soap brain. And then the provider says, sounds like lupus, let me do some blood tests. Let me do some pathology on the patient with, if kidneys are involved and I biopsy the kidneys and turns out it looks lupusy. Hey, I have my diagnosis. And then you get your diagnosis. Once they're diagnosed, the clinical course for the disease is generally they have inflammation, then there's periods of flare, inflammation, periods of flare, inflammation, periods of flare. Okay? So the goal is to keep the baseline inflammation as low as possible and not have any flares. So that's sort of what we try to do. And this low inflammation means low disease activity will lead to less organ damage, and again flares that would also lead to less organ damage and high quality of life. So that's sort of our goal with these patients. Okay, and that's what we do. That's how we manage them. Now, before we look deep into management in detail, let's look at a couple of things. Okay. First, let's say we diagnose lupus. Well, we got to treat the lupus, but before we treat the lupus, there's two areas within lupus that we need to look at closely. The first one is lupus nephritis. Is the lupus damaging the kidneys? So for these patients, when they're diagnosed and for their regular follow-up visit, we actually actively do a urinalysis on them to screen for their kidneys and whether you're starting to see nephritic pattern in urinalysis. If we are, if we are, then we start to suspect that lupus nephritis might be developing. And so the providers then recommend a kidney biopsy, and then generally, if that is positive, then we treat the patient with cyclophosphamide. And that's to prevent the nephritis from going into chronic kidney disease and for that to progress into end-stage renal disease. Because when they progress, they become sicker more and they have a higher likelihood to die. So again, we give them cyclophosphamide so that this does not happen. Okay? So that's lupus nephritis. The other thing at the time of diagnosis is to see if they've got drug-induced lupus. If the lupus is related to a medication we are giving them, well, if we discontinue the medication, the lupus goes away. Ah, beautiful. So how do we know? Well, generally it's one of those big culprit medications that causes lupus. The biggest one is hydralazine. If the provider suspects it, they may order an antihistone antibody test. Remember that antihistone antibody? If that's positive, they've got drug-induced lupus. If that's the case, the provider will discontinue the drug, lupus will go away. Yay! Okay? So that's two specific areas within lupus to look closely at. There's some pearls. ESR-CRP, non-specific inflammatory markers. When they are elevated, they will show you increased inflammation in the body. They'll not tell you where the inflammation is coming from. But if there's no other source of inflammation, if I have patient at time T1 and at time T2, if the CRP is type T2 is elevated and the patient's got lupus, okay, and everything else being the same, this will tell me that there's higher level of inflammation versus if the CRP in T1 is low, which means low level of inflammation. So a patient at T1 is better controlled than T2. So I can use this to see if they're having flare-up. How bad is the inflammation in the flare-up? How's the disease activity? With lupus. It doesn't tell me though whether it's lupus specific or not. It just tells me how much the inflammation is. The other thing is with lupus flare-ups, the patients have fever. Well, the patient shows up in the clinic, they may have fever, the patient has lupus, it could be a lupus flare-up, or the patient may have a sepsis or infection. How can they differentiate? So again, there's clinical, but sometimes if there's confusion regarding this or one is not sure, the provider may choose to order complement levels of C3 and C4. Lupus has low complement levels, and we talked about that with Pathology just a few seconds ago. Sepsis, if the patient is having infection, they'll have high C3 and C4 complement levels. Okay, so that's how we differentiate the two. So the last one is the bleeding versus clotting. So in your textbooks, you're going to see in some areas it's going to say the lupus patients have low platelets. And so you would think that would lead to increased bleeding, and you would be correct. However, also with lupus, in some patients, they develop antiphospholipid antibody. That means this antibody leads to increased coagulation or increased clotting. So again, it depends on the type of lupus patient you have. In some you have increased clotting, in some you have increased bleeding. And it's got to do with patients, lupus patients who have low platelets and no antiphospholipid antibodies will bleed more. Patients that have antiphospholipid antibodies and have normal platelets will coagulate more. Okay, so don't get confused. It's lupus, and lupus does different things to different patients. Okay, so now that we've looked at some pearls, how do you treat it? You don't, you manage it. How do you manage it? Hydroxychloroquine is the first line. Okay, and then you add more immunosuppressants to it. Okay, so remember, rheumatoid arthritis, methotrexate. Lupus is hydroxychloroquine. If there's a flare-up, steroids, corticosteroids, and taper as soon as possible. Okay. Lupus nephritis, we screen with urinalysis, and if there's indication that they might be having lupus nephritis, we biopsy, and they get put on cyclophosphamide. And they get referred to rheumatology to add more immunosuppressants and manage lupus-specific issues. Okay? So now that you know this, what do you think you'll do as interventions for this patient? You know, they come in with symptoms, let's get them diagnosed. Okay? Including referral to rheumatology for diagnosis and management. Once they get diagnosed, I want to make sure that, you remember the course? I want to make sure that their inflammation is low and there's no flare-ups. How will their inflammation be low? Hey, don't smoke. Don't expose yourself to ultraviolet radiation. Stay away from infections. Don't involve yourself in any triggers that will increase the disease activity. So sunscreening, smoking cessation. Take your medications. Adherence to medications, that will do the same thing. However, medications that suppress immune system increase infection and malignancy. So healthy lifestyle with immunizations. You know, if there's signs and symptoms of infection, they get managed aggressively. Get screened for malignancies or cancer. Okay. We screen them for end organ damage. And we screen them for symptoms. So if there's low platelets, we're really concerned about bleeding. If there's neural symptoms that are coming, we're worried about neurological effects of lupus. And when that be the case, we make sure we inform the provider about what's going on. Lupus nephritis, I think we've covered extensively. You see that one, that gets sent to the provider for biopsy and management. Okay? And that's lupus. And that's lupus. So just to recap real quick, we talked about lupus and how it's polyarticular, inflammatory, symmetrical, chronic autoimmune disease. We talked about how the nuclear material comes out and is not cleared quickly, and it's susceptible, gets tagged by the antibody, and then you have type 3 hypersensitivity. Patients, Loretta would be the prototype from Family Guy, and female minority. And then MD Soap-Brain would give you some of the symptoms you're seeing in there, with your diagnostic tests as ANA and anti-Smith. Anti-Smith is more specific than ANA, antihistone for drug-related lupus, and anti-double-stranded DNA for lupus nephritis. Right? So again, we talked about lupus nephritis. We talked about drug-induced lupus. Okay? We talked about fever in lupus versus sepsis. We talked about the non-specific inflammatory markers, CRP and ESR. We talked about bleeding versus clotting in lupus. We talked about treatment with hydroxychloroquine and steroids, corticosteroids for flare-up, and lupus nephritis gets treated with cyclophosphamide. Referral to rheumatology, and then nursing interventions in terms of getting them diagnosed, referring for management and diagnosis, keeping the inflammation down, preventing flare-ups, screening for end organ damage, adherence to medication, and then also complications of any medication that they're taking, especially immunosuppressants. So that's lupus.